Hello, everyone, and welcome back. Today, we're going to talk about one of the most overlooked sources of lost revenue in all of healthcare finance: underpayments. Now, if you work in revenue cycle, you already spend a lot of time thinking about denials. Denials are loud. They show up on reports. They have codes attached, and your team chases them every day. But underpayments are quiet. And by the end of this lesson, you'll understand exactly why that quietness makes them so expensive and what a disciplined organization does about it. We'll cover 5 things today: what underpayments actually are, how they differ from denials and write-offs, what they cost, why they happen, and the 3-phase workflow for finding and fixing them at the source. Let's start with a precise definition, because precision matters in this subject. A healthcare underpayment occurs when an insurance payer reimburses a provider less than the rate stipulated in the provider's contract. The key word here is less. The claim was not rejected, it was paid, just not paid correctly. And I want you to really sit with that distinction, because it explains everything that follows. When a claim is denied, the remittance arrives with an explicit denial code. Your system flags it. Your denial report catches it. Somebody works it. When a claim is underpaid, the remittance lands, the claim closes as paid in your patient accounting system, and the shortfall buries itself in the gap between the contracted amount and the deposited amount. No alarm goes off. No report flags it. The money simply never arrives, and nobody notices. That is why I call underpayments the hidden leak in the revenue cycle. They are structurally invisible to the tools most organizations rely on. Now, a common error, even among experienced revenue cycle professionals, is conflating 3 categories of revenue leakage that behave very differently. So let's draw the lines clearly. The first column, underpayments. Paid, but not correctly. The cause is typically a contract misinterpretation, a fee schedule error, or a modifier issue inside the payer's adjudication. The fix is contact-based variance detection, followed by an appeal. And here's an encouraging number. When appeals cite the exact contract language and rate exhibit, recovery rates run 70 to 85%. These are very winnable disputes. Second column, denials. Rejected outright. There's an explicit denial code. The claim is visible on standard reports the day it arrives. And the cause is usually eligibility, coding, or documentation. You correct and resubmit, or you appeal. Recovery runs 50 to 70% depending on root cause. Third column, write-offs. Accepted as lost. The balance gets marked as a contractual adjustment, charity care, or simply absorbed because the timely filing window closed. And here's the part I want you to remember from this slide. Many write-offs are mislabeled underpayments. A balance gets categorized as a contractual adjustment without anyone verifying that the contract actually allowed the lower payment. So think of it this way. Denials get the attention because they're visible. Underpayments are typically bigger in aggregate dollars, and write-offs frequently mask both. Alright, so how big is this problem? Let's look at the evidence. The industry benchmark, published in Becker's Hospital Review, is that providers lose 1 to 3% of net revenue annually to underpayments from commercial payers. 1 to 3%. And some studies put that figure as high as 11%. But the broader 2025 and now 2026 environment makes that even more urgent. Consider 4 data points. First, as of 2025, 41% of providers report claim denial rates of 10% or higher, and that figure has grown year over year. Second, MedPAC projects hospitals' fee-for-service Medicare margins will remain at negative 10% in 2026, the 5th straight year of double-digit negative margins. Third, the American Hospital Association's Cost of Caring report found that in 2023 alone, Medicare and Medicaid underpaid U.S. hospitals by $130 billion. Medicare covered just 83 cents of every dollar hospitals spent on care. And fourth, this one always gets a reaction. The AMA reports that commercial insurers' claim processing error rate stands at 19.3%. So nearly 1 in 5 claims processed with an error. The AMA estimates that eliminating those errors would save providers $17 billion a year. So when margins are this thin and error rates are this high, a 1 to 3% leak is not a rounding error. It's the difference between a healthy operating margin and a negative one. Now let's make those percentages concrete, because percentages don't pay salaries, dollars do. Net revenue per physician full-time equivalent recently hit roughly $669,000. Apply the 1 to 3% underpayment rate and look what happens at scale. A 20 physician group bringing in about $13.4 million in annual net revenue is leaking somewhere between $134,000 and $401,000 every year. Now, a 100 physician group has $67 million in net patient revenue, $669,000 to $2 million annually walking out the door. And a regional health system with 500 physician FTEs is exposed to $3.3 million to $10 million in recoverable revenue per year. There's also a strategic dimension here that's easy to miss. If your group is trying to attract capital, recruit talent, or position for a sale buyers compare EBITDA. A group that has captured its underpayments shows up to that transaction with a higher revenue floor and a credible operating discipline. Revenue integrity is a competitive advantage, not just a recovery exercise. And the legal record proves these dollars are real. In August 2025, a federal judge gave final approval to Blue Cross Blue Shield's plan to pay $2.8 billion in underpayments to hospitals and health systems. An arbitration panel ordered United Healthcare to pay $91.2 million to Envision Healthcare. And when Radiology Imaging Associates adopted automated underpayment detection, they identified $1.1 million in validated underpayments from a single payer. So why does this happen? Before we blame any single actor, let's understand the conditions. The American healthcare system itself creates an environment where underpayments thrive. I'll give you 4 structural drivers. 1. Plan complexity. A typical provider group bills dozens of payers, each offering multiple plan types, each updating restrictions yearly. Add the AMA's annual code updates, 270 new codes, 112 deletions, 38 revisions for next year alone, and precision becomes nearly impossible. The Kaiser Family Foundation found 43% of adults believe they received a medical bill containing an error. Some estimates say errors exist on 80% of medical bills. 2. The staffing shortage. 63% of providers report revenue cycle staffing shortages. When staff are limited, only the most pressing tasks get done, and underpayments drop to the bottom of the list. 3. Volume and burnout. A Brigham and Women's Hospital survey of 42,000 healthcare workers found that nearly half of non-clinical administrative staff perceived work overload, and about a third plan to leave their jobs. Overloaded staff make more errors. Errors produce underpayments. 4. Inexperience and prioritization. Flagging an underpayment requires comparing the payment received against the contract, a document most revenue cycle team members have never read. Physician groups juggle 12 to 20 payer contracts, and even when staff could pursue underpayments, denials feel more urgent. So individual underpayments get dismissed as too much effort for too little gain. That last point contains a critical fallacy, by the way. The money is not in chasing single instances. The money is in spotting trends and rectifying the root cause, so future claims pay correctly. Chronic underpayment should never be tolerated. Now let's classify the causes themselves. They fall into 2 broad buckets: payer-driven and revenue cycle-driven. Payer side first. Some payer errors are disputable mistakes in how the contract was applied. Let me give you the most common ones. Annual escalators. Your contract stipulates, say, a 3% annual rate increase. The payer keeps paying at last year's rate, underpayment. Improper bundling. Not every surgical procedure bundles with its follow-up. When the payer bundles 2 separately payable services into one payment, you're reimbursed at a reduced rate. Carve-outs and combined accounts. Confusion about which plan covers which service. Behavioral health carved out to another payer, for instance. Or 2 procedures on different days combined into one account, paid as one. Missed interest payments. Most contracts require interest on late payments. A payment arrives 60 days late. The contract says interest accrues after 30. That interest must accompany the payment. Plain processing errors. A transposed digit becomes a wrong CPT code, and a wrong CPT code becomes an underpayment. But then there's a second subcategory I want you to handle differently. Terms written into the contract itself. Lesser of clauses, where the payer pays the lesser of your charge or the contracted rate. Charge reduction provisions, stop-loss caps on what the insurer will pay. These will trigger variance alerts, but they're not errors. You agreed to them. The remedy isn't an appeal, it's renegotiation at the next contract update. Now, intellectual honesty requires we look in the mirror, because some underpayments originate inside the provider's own revenue cycle. 3 categories: billing, charging, and coding. On the billing side, invoice errors, incorrect national drug codes, missed payer-specific edits, and trailer billing, where a delayed claim submission means the claim gets adjudicated under a changed, less favorable policy. On the charging side, missed charges, pharmacy multiplier errors, get a dosage off by 1 decimal point, and watch what happens to the bill, and using deleted codes. Remember, over 100 codes are deleted every year. Bill with a dead code, and the payer simply won't pay it. And on the coding side, this is where some of the biggest money hides. Missing modifiers like modifier 59 for distinct procedural services cause payers to reimburse complex work at standard rates. DRG validation errors, where complications and comorbidities go uncoded, and a lower weighted DRG gets assigned. Procedure ordering mistakes, where coding the cheaper procedure first triggers a multiple procedure payment reduction on the expensive one, and transfer claims billed as regular discharges, which typically pay less. The lesson here: an underpayment program that only audits the payer is doing half the job. The same detection discipline must point inward. So how does a mature organization actually attack this? With a 3-phase workflow: detect, recover, resolve. And I want to emphasize, each phase is necessary. Skip any one of them, and you will either leave dollars on the table, or you recreate the same leakage next quarter. Phase 1, detect. Find the variance. This means digitizing your contracts and fee schedules, replicating the payer's adjudication math, and comparing every payment that comes in against what the contract says it should have been at the claim line level. Your practice management system's variance report is a start, but remember its limits. It misses documentation gaps, it misses process inefficiencies, and it struggles when EHR and billing data aren't integrated. This is precisely why providers are adopting dedicated contract management technology. Manual spreadsheet reconciliation simply cannot scale the millions of claim lines. Phase 2, recover. Convert variance into cash. Dedicate resources, a team, or individual focused solely on underpaid accounts. Group and prioritize by dollar amount, by payer, and by claim age, with special urgency for claims nearing the timely filing deadline, and build contract-anchored appeals. A successful appeal is specific. Claim identifiers, a clear variance statement of expected versus actual, the exact contract clause that supports your position, and the supporting documentation. Generic complaints lose. Contract citations win. Remember, 70 to 85% recovery when you cite the exact rate exhibit. Phase 3, resolve. Fix the root cause so the leak stays fixed. Run trend analysis. Which payers consistently underpay? Which codes? Which contract updates got missed? Feed those findings back to your revenue cycle teams. Use the underpayment data as leverage at contract renegotiation. A documented pattern of misapplied lesser of clauses is exactly the evidence that wins better language or higher rates at renewal. And then remeasure quarterly. Your prevention KPI is the repeat leakage rate by payer and code. If the same pattern keeps recurring with the same payer, the root cause has not actually been fixed. Let's consolidate what we've learned today into 5 takeaways. 1. Underpayments are paid claims that fall short of the contract. They are not denials, and they will never show up on a denial report. 2. The industry standard loss is 1 to 3% of net patient revenue every year, and for organizations with weak contract management, estimates run considerably higher. 3. The causes fall into 3 buckets: payer-driven, revenue cycle-driven, and industry-driven. Diagnose which bucket drives your largest dollar losses before you build the fix. 4. Recovery follows detect, recover, resolve. Detection defines the variance, contract-anchored appeals convert it to cash, and root cause resolution keeps it from coming back. 5. Underpayment data is negotiating leverage. Providers who systematically document payer underpayment patterns walk into contract renewals with evidence instead of anecdotes. Here's the bottom line. Every contract your organization signed entitles you to a specific payment. Payers, through error or through process, routinely pay less. And the structure of standard reporting guarantees you won't see it unless you go looking. The organizations that go looking are recovering 6 and 7 figures. The ones that don't are funding their payers' margins with their own. If you want to see what automated underpayment detection looks like in practice, MD Clarity's RevFind compares every payment against your contract terms automatically, surfaces the variances by payer, code, location, or physician, and tracks your recovery over time. For teams that need extra hands, their underpayment recovery specialists pursue the flagged variances through resolution. There's a link in the description if you'd like a demo. If this lesson was useful, subscribe for more on revenue cycle management and healthcare finance, and I'll see you in the next one. Class dismissed.